Hi, everyone, and welcome to our How to Connect with Families Through Technology on Child Health topics. Today, our speaker is Dr. Ramtekar, and I want to take the time to thank the Ohio Department of Health for their support with this training, and thank you all for attending today. Just a few housekeeping items. Our next and last training as part of the webinar of the month is September 29th on implicit bias. The training was moved and it is at 1 p.m. We do have resources available and you can access them on our website there. Our quality improvement project will be kicking off in December. It's a 9-month QI project with an incentive to participate. Action period calls and you're able to choose the screening tools that you would like to measure. Please keep your lines muted and cameras off during the whole training. And here's the flyer for the QI project. There will be a post-survey evaluation sent out tomorrow that includes a 90-day action plan. So please fill this out. And then I will go ahead and pass it over to Dr. Ramtekar. If there's any questions throughout the training, please ask them in the chat box.
Hi, good afternoon, everyone. Thank you so much for joining us today. It's really good to see some of the very familiar names again, and it's a pleasure to join you today to discuss a little bit of technology utilization for connecting with children and their families as we serve. I don't have any relevant financial disclosures, and other than maybe well-known websites like Google and Facebook and Instagram, we will not be talking about any products or vendors today. So a couple of objectives for us today are really around some of the different aspects of technology, which includes telehealth. Ultimately, we are in the business of healthcare delivery, and we are continuously thinking through and working on developing ways to engage our families in how we best deliver care. Part of that is going to be use of telehealth as a way of communication and care delivery. Thank you so much for your interest in really understanding and embracing the new normal as we have done for the last couple of years. We will also discuss some of the connection and ways to have best practices in social media use, which has been really becoming a norm in a way. A lot of our patients or families are getting their information, and there is no other way to be part of that channel in order to keep them safe, provide evidence-based information, and in some cases, dispel some of the myths that they might be falling into. Then we will talk about how to optimize the patient portal safely. Again, it's really a part of many common EMRs, and a lot of large group practices and health systems have already been utilizing it. But there are some other potential ways as a refresher that we could talk about. And lastly, we will very briefly talk about some common marketing strategies, operating word being free if possible, in order to grow your practice as well as retain the current patient base. So starting with telehealth, since 2020, when the declaration of public health emergency happened for COVID-19, there has been renewal of a lot of PHE flexibilities almost quarterly. I think last update was in July, and we are still currently under the federal PHE, even though state may or may not have continued it. So a few things to note are, from modality perspective, there is now audio only type of visits that are permitted. Again, fairly limited use, generally for check-ins, follow-ups, things like that, and really should not be utilized as a mainstream or replacement to video visits. Now that it's being permitted, we can continue to use it, but we probably need to start thinking about how do we minimize audio and maximize the video or in-person care. Second piece is location. We are still allowing home as a site of delivering care. Now, fortunately, we don't really have the confusing terminologies like originating site or a distant site, because how it was conveyed was exactly opposite. And now we just call it patient site and provider site. So home as a location for healthcare delivery probably will continue as some of the flexibilities are being made more and more permanent. There has been some movement towards schools as being sites as well. However, there will have to be some considerations as to how do we work closely with school as a single practice or a group practice, and if we do not have established relationships as a health system with the school. How do we then interact with FERPA in addition to HIPAA? And how do we collaborate and coordinate with school-based professionals like school-based nurses and school counselors as we're trying to deliver some of the pediatric healthcare in the school settings as well. Again, it's a dynamic area that we probably will need to keep an eye on, but it's a great way of capturing our patients where they are and getting the information from a very important source of school personnel like teachers and school nurses and school social workers. From consent perspective, there have been some relaxations. However, the general principle that is being recommended moving on is to always explicitly call out that the care delivery is being happening through telehealth. And in some cases, it's also a good idea to keep a statement or make a statement about potential limitations of telehealth, including inability to do the physical exam. Not that it's inferior, not that you're not able to do the very equal and high quality patient care on telehealth, but because there's not a lot of established data and standards, you probably want to make that statement and continue to make that statement in our general consent and medical record note. However, up until now, it has been fairly flexible, and general consent requirements have been the same, whether it's in person or telehealth. From services perspective, there has been a lot of expansion of different services. So for example, in your primary care practice, if you have care coordinators, if you have social workers, or you have therapists that are licensed clinical social workers and not necessarily psychologists, all of them were now allowed to deliver care through telehealth. It seems like it will continue to be very permanent change for us, which is very positive. From licensure perspective, there have been some flexibilities, as you know, that there have been some waivers for adjunct states and our neighboring states, where we did not necessarily have to have a license to practice while we delivered care for those patients who were coming from those catchment areas. And that's true mostly for our counties that are bordering other states, or in some cases, if you're a specialty practice, then there is a draw from across the state line as well. So in those cases, there were some waivers. Now, there has been a lot of recall of all of those measures, and now all states are reinstating their own rules. However, the good news is that in July of 2022, there was a full training that occurred about the IMLC, the Interstate Medical Licensure Compact, going in effect for Ohio, where Ohio is joining many other states in this IMLC process, so that it will help the process from efficiency as well as speed as well as cost perspective, where physicians can apply through that IMLC to get multiple state licenses instead of going to each state medical board and getting those. So it's going to be very good, particularly when we are thinking about not just the ongoing patients, but the patients who age out and might be moving to a neighboring state for college, or the families moving, but they would like to establish the relationship and continue with you as their primary care providers, at least during the transition period. This is going to be super helpful. I would really encourage you all to go to the Ohio State Medical Board website and look for IMLC training that was done on July 22nd. There are always dynamic changes in the telehealth arena as we are using it for various purposes, whether it's direct face-to-face care, or for care coordination, or for asynchronous care, or just for communication without necessarily billing it as a clinical care. And so it's always a good idea to stay on top of all of those potential changing landscape regulations in this area. One of the good resources is Center for Connected Healthcare Policy, or CCHP, which always keeps all the state related, or all for all 50 states, policies and regulations and potential pitfalls and individual state medical board information regarding telehealth and digital technology are very up to date. And obviously AAP also creates resources, compiles and distributes about whatever relevant changes that are happening. So moving forward with how do we then redefine the scope of telehealth as we are returning to the new normal, where some are in person, but many are continuing to be on telehealth. One of the very important things during this forced quasi-experiment in understanding the utility of telehealth in the last 2 years has shown us that telehealth is very capable, particularly as we think about the ambulatory practice. Primary care and mental health were leading the utilization of telehealth across the country. And so after a lot of data, both published and unpublished, we recognized that telehealth in its very basic form of two-way audio-visual communication is very feasible. The feasible is because, as you saw, that as your practices pivoted in utilizing telehealth, it was very well adopted and accepted by the parents, the families that we have. For many months, it was the primary tool of delivering care. It's also very reliable. The diagnostic accuracy and errors are no more than in person. And obviously, you want to clearly triage the symptoms and triage who needs to come in person, who needs to go to emergency room, who can go to urgent care, or who can be seen by telehealth. But in general, for the cases that are most suitable for telehealth, the diagnostic accuracy was no less than any in-person care. So very reliable, also scalable. Prior to 2020, the overall telehealth market when it comes to independent practices and healthcare systems or group practices was less than 4%. By the mid-2022, now it's about 96%, and all the telehealth companies only share a very small market share for telehealth. Now, it also has a very distinct benefit of utilizing the screening tools. You remember the screening tools that are filled out in the waiting area, they're rushed. Often the responses are questionable and not very reliable, and often depend on what happened that morning or what's happening in that moment. And it doesn't necessarily give us the true reflection and the full picture of what has been going on during the visits. Now, with screening tools being adapted in the telehealth workflows, it truly provides a much better data about what is the true status and what is the day-to-day variation for anything. For example, in mental health use case, it really reflects whether the symptoms of depression or anxiety have been stable, up or down, worse or better in the interim when they filled out the form in a really relaxed home environment, rather than reflecting if there was a fight between a parent and a child on their way to the pediatric office, and that's when it was filled out, and it shows that everything is worse. It's also ecological. Kids are the digital natives. They always are putting things in context with regard to what's going on in their surrounding. So when we are utilizing telehealth and we are seeing them in their natural environment of home, it also provides us with a lot of data inputs of their surroundings. It also provides us with better information about any potential social determinants and other factors that may be contributing to the diagnosis or affecting the overall presentation. So it really provides a much better source of information for us during our face-to-face examination, rather than seeing them in an artificial office or clinical environment. It also has allowed us to have multiple informants participate and provide all the relevant data or to different perspectives that gives us valuable information for sound decision making and taking appropriate clinical steps. Now imagine the three-way video call, or the parent that is out of state, or if it's a family with two divorced parents, or if there is DFS involvement and there is a caseworker who wants to join. All of those things are really possible and seamless with telehealth adoption as well. There are some limitations when it comes to physical exam, for example. The only reason it's a limitation is because the established tools like peripherals for vitals, like Bluetooth-enabled stethoscope or otoscopes, or different other devices that provides you the real-time physical exam type of data with the API integration with your video tool that you're using. A lot of those are still not very common. They are being used in specialty or large healthcare systems, but really, given the expenses, given a lot of investment that goes into creating that telehealth toolkit, it has not been a common practice. Fortunately, there are certain organizations and health plans and ACOs that have been sponsoring these kind of kits for their covered lives. But again, when it comes to a lot of commercial plans and independent small practices, it is still kind of out of reach until it becomes it's a norm. And so from physical exam perspective, it continues to be a little bit of challenge, which again could be appropriately documented in the consent or your document. There is also some dependence on reliability of technology. While we all have good access to broadband in appropriate urban areas, there are still very pockets of underserved areas within urban areas, as well as the rural areas have very patchy connectivity. And in those cases, it becomes a little bit difficult to have that reliable, well-rounded and informative clinical interaction with them. And so sometimes technology comes in a way, so it goes both ways. While it's a huge tool, it would also be a limiting factor. And lastly, and we see this in both physical health and mental health, that it could be a tool for avoidance to come in when needed. And we see that in immunizations, well child visits, mental health screenings, or mental health follow-ups. And a lot of times there is this misguided perception that, well, if we have been seeing our doctor on video, why do we have to go in? And we really have to make sure that we provide appropriate psychoeducation and education to our families, that it's not really a replacement for physical health or in-person care, and that it's really a supplement, complement, and should be used only when it is appropriate. And so a lot of times, a lot of anxious kids who are socially anxious, kids with OCD who really are always afraid to go out, have been utilizing this as a shield for not really taking the step and coming to the doctor's office. But that's when we really have to set the limit and bring it to the parents about what is appropriate and not appropriate. Again, telehealth becomes an excellent tool of that communication and connection to really convince them and appropriately bring them up to speed for appropriate treatment adherence, which could be completely a lost chance if we did not have telehealth and technology to help us. Now, not everything is great. There are some of the issues with scope and post-pandemic lessons that we have seen. My apologies. We have learned several things from post-pandemic lessons of telehealth and technology utilization. One is that there is a digital chasm, and there are social determinants that create a lot of inequities in access. And part of that is about digital literacy, not just on the part of our patients and families, but also on the part of providers. So it's very important that we also become good digital citizens and invest in gaining knowledge through CMEs and other trainings in becoming very savvy when it comes to utilization of telehealth and technology in healthcare delivery. Unfortunately, most vulnerable population who don't have access are most likely to struggle because they are also the population who may be struggling with social determinants and not getting access to telehealth. There are also concerns about privacy. There are no private spaces, and you may have noticed that there is a lot of use of bathrooms where adolescents, because of lack of private space, are using that as a site to have a conversation with the doctors. There's also an emergence of concept called car therapy, where teenagers are utilizing their cars of the family in the garage or in the parking lot to have a private conversation because there's no other safe and private place. Um, there's also concern about abusers who are now there in the vicinity and are lurking around. And that's why sometimes it's very important to specifically ask who else is in the room. Some of those telehealth competency things that we have reviewed in some of the previous telehealth trainings. But those are some of the potential difficulties that we have to proactively discuss and plan for. There's concern about rolling back of some of these flexibilities. While those concerns are becoming less and less real now, because based on all the federal as well as statewide movements, it seems that majority of the flexibilities will remain. There's always the need for plan B if suddenly there are changes in the regulations and we have to go back directly to our prior to pandemic, pre-pandemic normal, and now suddenly we have to facilitate transition to in-person care, and the families who really have been struggling with transportation, other social determinants, or even the capacity of the clinic all needs to be appropriately addressed. There is concern for non-parity of reimbursement. Currently in state of Ohio, there's not a parity of payment when it comes to telehealth in general. And that kind of leads to some discouragement that should we really use it or not? Does it make sense? And there are also rules and regulations around what if the disposition after the telehealth visit is to bring them in within 48 hours for in-person, then that visit is not getting paid. So there's always those concerns about non-parity. Fortunately, there is a lot of advocacy around getting the same level of reimbursement for ambulatory outpatient pediatric practices or primary care practices. Other issues about hospital or facility fee in some organizations and large group practices, depending on how they're structured, would be well eligible and others not. And so that creates a lot of discrepancy between the reimbursement rates for you. And that definitely poses a challenge financially to sustain telehealth. Again, it seems that the direction is in favor of practitioners, and so there's more to come. There has also been a concern of fraud, abuse, and quality of care, particularly when it comes to phone visits, that how do we make sure and verify that the person who's stating that they are actually the ones they are. However, a recent AMA study that was published just 2 weeks ago has shown that there's really no concern for more fraud or abuse of telehealth than what we would see in in-person care as well. And so fortunately, that is going to dispel some of the myth that has been restricting the utilization of telehealth. Then there is about quality, that, telehealth is somehow subpar or suboptimal to in-person care when it comes to quality. And that myth has also been dispelled significantly with a lot of published data. However, there needs to be a little bit of change in the landscape about how do we integrate telehealth. And a good example would be how do we care for depression in primary care practice as an integrated telehealth program. So initially, when the telehealth became very available and there were early adopters, we had somehow restricted ourselves and our patients into whether they are fit for this particular service, a follow-up service or not, or whether they're severe, not so severe, stable, they're just on treatment phase that is pretty much self-guided and we don't need to do anything else. However, that really was a disservice to a large population Whereas the true and most efficient way of doing it is to think about the episode of care as to how and when are we able to connect with the families using telehealth and other technologies by the episode of care. Which stage of their episode are they in? For example, if we were to think about GLAD PC uh, um, guidelines for depression care in pediatrics, we do the intake, and then there has to be a follow-up for every 2 weeks. If there is a med management, then there definitely has to be follow-up every 2 weeks for about 3 months, and then it could be spaced out. However, as you know, a lot of that follow-up is just really a check-in. A lot of times, a follow-up is to make sure that there's no news, which is a good news. In other words, it's about side effects and side effect monitoring. In other cases, the follow-up is just around providing education to parents about safety planning or treatment plan for how and when they could connect with therapists, what would be the goals, and what are the things that we need to think about. There's a lot of care coordination type of check-in plannings. But at other times, you are also looking for some physical exam and physical signs and symptoms as well. So the best way to really think about integrating telehealth and in-person care is to really think about what are the different steps in the guidelines and mapping those steps on what's feasible with telehealth or not. For example, intake assessment, probably best done in-person care because you're also looking for any other medical underlying etiologies. But if the follow-up care is just to discuss the treatment plan because you have to discuss the lab results, you have to review the rating scales, you have to review any other information, probably bringing them in for in-person visit, not necessary. At that time, if you decide to start an SSRI and you want to lay eyes and make sure that there are no other side effects, well, that follow-up visit after 4 weeks could be in person, lay eyes on them, do the physical exam, make sure that there are no physical symptoms, restlessness, or any other side effects from psychotropic medications. And then the next visit about checking in to make sure that there is some improvement or no improvement could certainly happen again in telehealth. So this is the discussion that could happen in our minds in practice through clinical pathways as to when do we utilize telehealth and when do we not, but also could be a great way of bringing in the parents for better adherence to treatment because, as you know, more than 60% of the times, the patients are lost to follow or are not really returning to the clinics within the time that they were asked to. And a lot of times it's because of some difficulties with taking time off from work, some other financial difficulties, logistics, transportation, and a lot similar things that probably contribute to their depression or chronic medical condition anyway. So this is a great way of thinking about using technology, using telehealth for connecting with the families and patients, but also bringing them on board with adherence and really delivering high quality, really guidelines-based care as well. As we think about telehealth as the primary mode of technology in delivering care, we also have other technologies. So ultimately, it's more about using the tools that our patients and parents, and at this time, most of the parents are millennials, particularly for the kids that you're seeing in your practices. Then some of the tools, particularly social media tools, could be very helpful. So a good thing about social media is pediatricians have been one of the leaders in healthcare in appropriately adapting it for various purposes. And to think about some hashtags, there are put kids first or access for kids or vaccines work. All of those hashtags have been used very proactively on different social media platforms for evidence-based information and advocacy campaigns as well. Now, that is done at a large population level, but you can certainly do it for your specific catchment area, practice, and current as well as potential patient population in your base as well. Now, there are many, many different platforms. There's Twitter, TikTok, Facebook, Instagram, YouTube, Tumblr. There are many, many other sites that are coming up as well. So don't restrict yourself. Find your comfort zone depending on what you're used to, what you're not used to. If you're courageous to dive into something different on your weekend to explore more, absolutely. Because not doing it is not an option. Almost 50% of the millennial parents generally take a look and follow their practices or clinical providers. More than 65% of any new patient are always looking for online reviews before they make a decision about their potential new healthcare provider. So it is really a missed opportunity if we are not proactive in appropriately utilizing the social media. However, as we do that, we really need to make sure that we answer the two primary questions. What is it that you want to do on social media, and why do you want to do it? So when it comes to what do you want to be and what you want to do, you need to come up with a role. What is your role? Are you a creator of content, which is a lot of new content that you create? You write your own thought piece, you summarize an article, you provide opinion on an upcoming guideline, or you could be a curator, which is another biggest way of being a good, active social media pediatrician. Is you don't have to create new content, but you can compile the best practices, the recalls, the updates, the guidelines, the statewide things, the local community news when it comes to healthcare. You could just be compiling, digesting, and presenting the outside content for the benefit of your patients. And that's a great way and possibly a simplest way of being active in social media as a pediatrician or a pediatric practice. And the third is influencer. And unfortunately, these days, being an influencer has been seen in a negative connotation because of a lot of misinformation and so-called self-diagnosed experts in the medical field without really having any expertise, or unfortunate things that we have seen with anti-vaccine influencers and campaigns with very large followings. Again, nothing wrong in it being a social media medical influencer if you have expertise in area and you have a large following with a large network of other experts in that area. But to begin with, curators followed by creators seems to be the more simpler way of how you do it. The next piece is, what is the purpose? Why are you doing it? And so that's where you have to clarify whether you're thinking about being a strong pediatrician voice to provide evidence-based public health messaging, or do you want to use it as an engagement tool so that a lot of the activities that your practice is doing is going out to our communities, to the patients, and they're also getting information about common health topics. And third is advocacy, which is again extremely important. And a lot of our AAP members and office holders have been very strong advocates from both public health, clinical, and with a little bit of slant of political discourse that is happening in the country, because some of those topics directly affect the healthcare of the children that we take care of. So we really need to make sure that we have answered these two questions and then come up with a strategy and plan to do that, because it's really not a passive way of doing it. It is really an active long-term strategy. Once you decide, then you can think about the next steps about who is my audience and what am I trying to share with them. Where can I share it? What is the right platform for me based on my style, based on the time that I have, or based on the resources that my practice has. And then talking through the benefits of social media from the practice perspective on your web page, on your social media page is also extremely important. So diving into some of the practical steps first and foremost, you really need to be careful and make sure as to who you are on a social media platform. Are you presenting yourself as an individual physician, or are you representing a practice? Which means that anybody and everybody who is in that practice, who's using that identity, will be held really responsible for anything that comes out of that practice page. It's extremely important for several ethical as well as legal and HIPAA-related concerns that we'll talk about in a few minutes. But to begin with, try to keep those two things separate. Even if you're a single pediatrician practice, keep your individual accounts separate with a very different privacy settings versus your practice, where you are providing medical expertise, not a medical advice or not a medical opinion, but really expertise as a healthcare provider, as a pediatrician, versus in individuals when you are commenting on your friends and vacations and other kind of things as well. From that perspective, as you embark on it, with the first step of creating a profile, you want to make sure that you use the consistent username all across different platforms. That way it becomes really an identity of yourself or your practice, and people can search easily for that. Check settings for privacy as well. Good example is, would you allow people to tag you or your practice into their private post, which could be seen as an association? And we'll talk about that in a moment, how it really affects from legal regulatory perspective. But make sure that you are very aware of what are the privacy settings for each of the social media platform, because they are different. Then complete all the information and update them. A lot of times what we have found is practice moves, there's change in phone number, there are new providers listed, or they have a new web page or website, but none of that gets updated. And that really leads to unfortunate event of people thinking that the practice is not active anymore, it's not available anymore, not taking new patients, or whatever interpretations people might draw. That we want to make sure that the profiles are continuously updated for any changes. After all, it is a way to communicate information. Next is know your audience. Who are you trying to reach? Posting an article in AAP journal or a newsletter or LinkedIn is a very different strategy than posting something for the parents and the families or teenagers. So we need to really know who the audience is and then come up with the content to share. Now, we also want to make sure that we are authentic. We are really reflecting the philosophy of the practice or philosophy of a physician as we are discussing some of these things. Ultimately, it is representation of what are you trying to do for the community and what are the services that are offered. There are many different ways of accumulating that information, both from official sources, newspaper articles, and there's a lot of tools and resources on AAP website about some of those content ideas. But when it comes to timing of social media posting, you probably want to not be the first one to be out there as a small practice or a group practice. You probably want to take some time before some information is reposted to make sure that there is some stance that is out there from your professional organization or the state health department or other reliable sources. You probably want to stop and think before you repost something that somebody else, i.e. non-professional, non-official organization post, because things could be activating, provocative, and many other things, but they may not be accurate. And just by the virtue of reposting, liking, or tagging, you somehow portray that you are associated with that misinformation, and that could really land you in unfortunate trouble. So we definitely want to avoid any of those perceptions. So as you're thinking about how to find content, these are some of the good resources. From AAP newsletters to state medical boards to AAP website, there are AAP, APA, many other professional organizations are continuously putting out a lot of content. I think just a few weeks ago, AAP also announced the creation of new National Center for Social Media Engagement, which is going to put out a lot of important tools that could be customized for your local tools. Now, as I said earlier, we always want to think before we post anything. And this is what I mean by that. A lot of times there are posts, there are comments, there are provocative things that are said on your web page or are tagged or you might want to just jump in a hot debate or discussion. In all of those cases, let's find out the real purpose and go back to the real reason for why you're engaging in social media as a practice. Just make sure that it's truthful, it's helpful for your audience, which is the families and patients in your area. It is inspiring. Is it necessary, and is it kind? Making a strong, opinionated statement often can cause strong and intentional emotional reactions in the mind of your constituents, which are your patients and families and your communities, and you probably want to stay out of it. Now, as we're thoughtful, as we're providing all the good content in it, it's also very important to make sure that we navigate the inherent complexities in the use of social media. There are some of the key considerations. One is having a good digital citizenship. The THINK acronym definitely speaks to it. You probably want to separate out your professional and personal accounts and stay very professional and follow the same professional code of conduct on your professional account. However, as we all know, as we live in the communities, as our children go to the schools in the same communities and probably are friends with some of the families that we also serve, and as we are active citizens of the community, even on personal accounts, we probably have to bear an added burden that many other professions may not have of being very, very professional. We probably want to also have adequate privacy settings for your personal accounts, not so much for professional accounts if you are stopping any potential settings like tagging or commenting. If you're allowing comments to be made on your Facebook page, for example, you probably want to have a system in place for continuous monitoring, because there may be unfortunate incidents where somebody comments a very specific PHI, leaves a bad review, or shares something very acute and concerning, that if you are not able to address it or don't have a process in place to address it, you could be liable, because ultimately they found a way to communicate with you and you could not respond in a timely manner. So it's important that based on very clear instructions on your page, either for Facebook or Twitter or Instagram or TikTok, which clarifies that none of the information there is a direct medical advice or not a replacement for direct clinical care or in-person care. You also want to make sure that there are other settings like pop-ups that come up when somebody talks about suicidality or harm to others, where the pop-up could provide information about calling 911, ER, or in mental health issues, 988, or National Suicide Prevention Lifeline. We also need to make sure that our code of conduct is very, very clean and clear, where nobody else is able to tag you in anything. So there are settings on all of those websites and social media platforms that makes sure that the permission is always asked before someone can tag you into their post, even if it's a good post. As a parent of very young children, something is very clear, that even if my kids are not speaking, they're always watching. So our online presence and citizenship is extremely, extremely important, because that's the way we are modeling ourselves to the communities for whom we are really the caregivers. From liability concerns, the casual self-disclosure, whether it's about your own healthcare, whether it's about your own past, or anything else that might be perceived or misinterpreted or related to something happening to the patients or in the community, could be a concern from both ethical and liability concerns. Now, it's possible that reposting misinformation or just responding to a comment could really be seen as providing medical advice and eventually enters you into a patient-doctor relationship, even if you have not seen that. And so we really need to make sure that we are very, very careful about commenting on a specific advice, specific condition, specific question. It's always a good idea to redirect them to your office or to your official link. Lastly, when it comes to regulatory pieces and HIPAA, as you know, there are about 18 different types of potential identifiers, and we want to make sure that everything is de-identified. A lot of time, it's imperative that you also showcase, with families' permission, some of the good outcomes of your excellent clinical care, but that's a whole different process with appropriately documented written consent and assent from both parent and the child, if they're teenagers, before you're able to post it. Otherwise, you could be really liable from legal perspective. Also be very careful about what could be perceived as a potential identifier, even if it's not officially an identifier, especially if you're in close-knit and smaller communities. A good example was one of the colleagues had posted about a pharmacist in a small town who worked at Walgreens, and it was a de-identified story. Everything was good, but somehow they said the parent is a pharmacist. They said both parents are pharmacists at local Walgreens in that county. Well, there was only one Walgreens in that town, and everybody then were able to find out whose child it was who was struggling and had contemplated suicide. And it was not a good outcome reputationally as well as professionally for that provider. And so we really want to be very careful when it comes to even de-identified stories, and we want to make sure that there is always a written consent anytime you're posting anything about patients, let alone pictures. Even verbally, if you're sharing something, it's very, very important. Other pieces really around out-of-state commenters on your page. And if you do something, if you share something, then there are concerns around entering patient-physician relationship and trying to practice medicine without the license in that state. So you probably also want to make sure that you have some kind of disclaimer on your page about who your catchment audience is and who are your intended audience are, etc. And then lastly, when there is a bad review on your website, web page, or social media account, it is often coming from a patient. And you want to be very careful and thoughtful in responding or choosing not to respond for it, because it can certainly have a potential of inadvertently disclosing some kind of PHI as you're trying to defend the action or provide an explanation. And again, it's always the best idea to have a generic response about acknowledging that they had a perceived bad experience and that it would be helpful if they could call the office and somebody could provide some attention to resolve the problem or take any other steps. But you definitely do not want to actively respond and be really reactive to any of those things. Other piece of technology that we always use, like always, are related to patient portal. Now, we all have been using patient portal in a very transactional way. Those are for scheduling appointments or providing information, billing, any other after visit summaries or updating medical history asynchronously. But now we have a chance to change from transactional to very relational use of our patient portal. So one thing is it's a very good tool to comply with the 21st Century Cures Act when the patients can directly have access. However, we also need to consider that in pediatric practice, there are certain things around patient confidentiality and privacy when it comes to our minors. And we really have to be very careful around how do we do that. User experience considerations are extremely important. It's all about user experience these days. And so if the information is not accessible right away in an appropriate places, then it could be really challenging. It's really a good engagement tool for treatment plan adherence. So while we have been using patient portals as more and more patient-driven or one-directional tools, these now could be great tools for sharing resources, sharing links, sharing any informational material, handouts, or even obtaining any of the rating skills as well. It's all there for mental health. It's a great use case for self-regulation skills as well as safety plans, and where they can easily access the safety plans directly from the patient portal or can communicate with you about any particular changes. So it really could become a very bi-directional relational tool for engaging our patients and our families. However, there are some caveats. First one being balancing the privacy and engagement of our patients and their families. There are ways of creating either proxy accounts or separate account for parent and teenager. More often than not, they have to be present in person for the first visit in order to set that up. Otherwise, depending on the state laws for consent, you probably want to have a system in place where there's not disclosure of a lot of information without the teenager's assent to their parent. There are also, again, things around two parents, who's the primary account holder, and how do we provide access to the second parent, etc. So again, when you're setting a patient portal, it's always a good idea to have some help from the IT support or a designer of EHR to help you make sure that all of those things are in place. Then there are about setting expectations. And a lot of that comes in when there is asynchronous release of information without your review. For example, lab results or any procedure results. More often than not, we want to discuss those things proactively with our patients and their families, but because of the Cures Act and because of the portal settings, they could be released to them much in advance. That can lead to unnecessary panic, a lot of Googling of the results and what it means, and misinterpretation. And so we want to make sure that even though those results are released, to probably not to engage too much or think too much about it without discussing it with the pediatrician or the pediatrician's office. And that needs to be made very clear in the educational materials or the message that goes out with any kind of lab results. And the fact that it is not really a replacement for follow-up visit, that it's just a simple question for you, doc, is not an appropriate use of patient portal, and some limit setting is extremely important. Shifting gears a little bit into how do we then try to market our practice appropriately, both for retention of our current patient base and for acquiring new patients as well. So it all comes down to perception. And the single tool other than social media right now is our website. And so there are some W and H components of our website that we always have to think about. We've got to make sure why your practice is different and what is the practice philosophy. Who are the providers? And there should be profiles of all the providers with things that are very personal in addition to their training on that to really reflect the personality. It's always a good idea to put the links, as many links as possible on your website, whether it's provider profile, click the link and it opens it. Don't put everything on just a single web page, and we'll talk about it, why that is. Then where is the location piece, but also sharing that you offer telehealth really bumps you up into the patient selection criteria. What services are provided, including mental health, how they can contact you, including a smart virtual assistant you might just have seen, and it's a very simple, relatively inexpensive technology that you can integrate into your web page, like Ask the Assistant, and it's an AI-based common Q&A that patients can type and get an answer right away. And then what's the value add about the timing of services? Are you available on weekends? Are you available after hours, or do you have hospital affiliations? All of those things should be very made clear with lots and lots of links in that. And it's not just for engagement and retention, but also for sharing the value proposition of your practice. Now that everything is a whole child approach and whole child care, it's a great way to showcase both physical health and mental health support that could be provided through your practice. And so more than a practice, it's really a primary care medical home and a medical hub. So there are different things that your practice might be doing, would want to consider doing without necessarily any additional expenses that you probably want to highlight on your web page or website to retain our patient base so that they're getting all of their care through your practice. The second piece is about attracting new patients. And one of the most common things that you can do independently without much external help or outsourcing is utilizing the search engine optimization, or SEO. Most of them are free. It shows you on the top of any search engine with certain keyword search like pediatrician or pediatric practice. Now, how do we know what keywords are useful and what goes on a search algorithm? A simple free way is to create a Google Ads account. And there are tools about keywords and keyword planners that you can create in the Google Ads account, where you can provide information about your website and your practice. Now, it's a very free website traffic, but it again is not passive and is very tied to the content of your website. And there are 4 key elements as to how to do it. There is something called as domain authority of your web page. And what it means is that, does it add value over time? So do you have articles, updates, recalls, content? Does it have active links? The more active links it has goes higher up in the search optimization. So if you have providers, if you have locations, put links in the primary web page that shares with the search engine that your website is providing a lot of value over time and has a lot of other outside connections or inside connections that is reflected through the links. And then lastly, the quality engagement is very important, along with quick access to relevant areas. So as you develop this domain authority, you automatically, for free, go up on any searches that somebody might be making. A little bit expensive one is pay-per-click, and there are different ways of doing it through sponsored content or paying the domain or web page or search engine for every time somebody clicks on your web page or website. Now that's a little bit of expensive one. You probably want to outsource that to a website manager, website engineer, or something like that. And lastly, there's social media marketing with sponsored content. Facebook, Twitter, LinkedIn, all of them do it. You have to have a sponsored account, pay some money, and then direct the traffic towards you. Again, all of it is if you have time, or the best way is to outsource it if you have a budget. So very important that you have some form of budget, unless you're going for the very first option of search engine optimization. Lastly, thought leadership. And thought leadership happens through a lot of virtual newsletters, a lot of articles, school boards, for example, magazines that are there for local communities, presenting at Ohio AAP, or writing short articles in our newsletters as well. All of those things create thought leadership, practice leadership, and social media presence that shows strong, high-quality care that adds value to the community you're serving, and that ultimately leads to growing of your practice. So we're going to skip this slide about adapting the new normal. It's very self-explanatory, and in the last couple of minutes, we'll take a few questions.
Does anyone have any questions for Dr. Ramtekar? Thank you so much for presenting. That was great information. If you have any questions, please put them in the chat box. Thank you for the comment. Okay, well, if there aren't any questions, we will wrap up. If anything comes up, please feel free to send me an email and I will get it to Dr. Ramtekar to answer your question. Thank you again, Dr. Ramtekar, for joining us. Thank you again to ODH for the support with this project. I will send out the survey for CME and MOC Part 2 credit tomorrow. And if you have any questions, please feel free to email me. Thank you again, everyone, for joining us, and I hope you have a great rest of your week. Thank you, Dr. Ramtekar.
Thank you all. Thanks for joining. Sorry it took longer than we thought,
Okay.
but we are open to a lot of questions and responses asynchronously, as Alex mentioned. And appreciate you all joining, and have a great rest of the day.
Yes, thank you all.